Next, we proceed to the symposium of managing acute complications of diabetes. So I invite the panelists, Dr. Rahul Jain, Dr. A.K. Oja, Dr. Viswajit Banerjee, Dr. Supriya Datta and Dr. Agnit Pal. Please join us on stage. And do we have Dr. Gaurav Bhaduri?
Can we have Gaurav's slide, please? This is a very important practical topic, and that's why I introduced this panel. And I can tell you one thing: this panel is extremely experienced, and they are managing day in and day out the complications, not only in diabetes but other as well, because they are attached to most of the big hospitals. So we have Dr. Gaurav Bhaduri who will be moderating the session, and will be looking at every aspect of acute complication. If you have any query, you can always address it later after all the 5 speakers have addressed most of the issues as far as acute complications are concerned. So Dr. Gaurav Bhaduri, he is a... Can we have his slide? Okay, so he is a consultant department diabetes endocrinology at Parkview Super Specialty Hospital, Salt Lake, Kolkata, and Apollo Sugar Clinic. And he was a fellow of Indian College of Physicians and fellow of Diabetes India. He has basically almost all the qualification which is needed for managing acute complications. Lots of awards: Subhash Chandra Moitra Memorial Gold Medal, Saraju Roy Memorial Silver Medal, Dr. Vidhan Chandra Roy Memorial Prize, and he is speaking in the Vidhan Chandra Hall as well. So that's important. And Sidhu Bala Brigendranath Award, the first prize in abstract percentage Diabetes India 2025, faculty at various national and regional conferences, numerous publications in both national and international journals. He is the author in Bench to Bedside, focus on secondary diabetes, and member of various associations. Thank you, Gaurav. You can take forward from here. Gaurav, please.
Thank you, Dr. Patni, for the very kind introduction. And I welcome you all for this symposium on acute complications of diabetes. So I have a very esteemed panel with me who is going to talk about this. I will just introduce a few slides to just brief you about what we are going to discuss today. So diabetes is not just a chronic disease. Acute complications also account for significant mortality, particularly in the low and the middle income country like India. Low insulin adherence, erratic access to insulin, and infectious disease burden contribute to the acute presentations globally. We must remember up to 50% of DK admissions are actually preventable with better education and follow-up. Now coming to DKA, which is one of the most dreaded complications of diabetes, if you look at the pathophysiology, it's about the absolute insulin deficiency, along with excess counter-regulatory hormones leading to lipolysis, ketogenesis, and metabolic acidosis. The onset is very rapid, usually within the first 24 hours. The triggers are the missed insulin, infections, myocardial infections, and in the era of SGLT2 inhibitors that also contribute. Increasing in type 2 diabetes, though it's primarily seen in type 1, but it is also increasing in type 2 diabetes and also in post-gradient surgery patients. Remember, infections, especially UTIs and pneumonia, they trigger over 40% of DK episodes in adults. Coming to the clinical features and management is usually present in a classic triad of hyperglycemia, ketonemia, and metabolic acidosis. The usual signs are polyuria, polydipsia, dehydration, too small respiration, and mental status change. If you look into the investigations, what we usually find is glucose of more than 250, pH of less than 7.3, bicarb of less than 18, and a high anion cap of more than 12, along with positive serum or urine ketone. In the management of DKA, the fluids play the most important role and is the first priority. followed by electrolyte monitoring and repleting potassium or magnesium if and when needed. Then comes the role of insulin. Usually IV insulin is preferred after you correct the potassium if the potassium is below 3.3. And we need to keep on monitoring the glucose, the ketone, the anion gap, as well as the electrolytes. Now, cerebral edema is a rare but feared complication. Specifically, it happens in children during overtly rapid fluid correction. So this is some important point we should keep in our head. The hyperosmolar hyperglycemic state, it features a glucose of more than 600 along with the serum osmolality of more than 320 with minimal or absent ketone. It again presents with profound dehydration but without any significant acidosis. That's a little bit of difference in between the DKA. It occurs more common in the elderly with type 2 diabetes, and often these patients have a lot of comorbidities. The right hand side you can see a few of the chart, one of the chart where the few of the differences in between the DKA and HHS has been presented, but we'll talk about this later in the question and answer. The HHS has a higher mortality rate than DKA, partly due to late presentation and because of the presence of different comorbidities. So we can basically see that both DKA and HHS, the principle of emergency management revolves at the first priority with fluid resuscitation, electrolyte monitoring and replacement if needed, and insulin therapy then on. Hypoglycemia is on the other spectrum of all the complications we talked about. So we have the level 1 of less than 70, level 2 is less than 54, which is considered clinically significant. Level 3, it is severe hypoglycemia which requires external assistance. The hypoglycemic symptoms, autonomic and neuroglycopenic, you can see over here. The common cause is obviously excess insulin, sulfonylurea, missed meals, alcohol, specifically binge alcohol drinking, exercise, renal impairment or sepsis. There are certain high-risk factors like long-standing diabetes with hypoglycemia unawareness, elderly patients, specifically those with cognitive decline, they are at very high risk. Now coming to another complication which we call as acute infections in diabetes. Now why diabetics are susceptible to infection? It's because of the neutrophil dysfunction, impaired chemotaxis and phagocytosis. Hypoglycemia impairs the complement activation pathway. So these two are at the very core pathophysiology why diabetics are more susceptible. The notable infections are the mucormycosis, erythematous pyelonephritis, necrotizing fasciitis, and tuberculosis. In India and other tropical regions, diabetes is the strongest non-HIV related risk factor for tuberculosis. So in a nutshell, DKA and HHS are emergency states with distinct management, early fluids, close monitoring, and cautious insulin use. Hypoglycemia is common and it can be dangerous, especially in patients who are elderly and who are on insulin or sulfonylurea. Infection, you have to have a very high degree of suspicion, and remember, early intervention is life-saving. And then health is wealth, so prevention is possible with structured care, education, and technology use. So let's shift from a reactive emergency care to a proactive prevention and a rapid response. So we start the panel discussion from here on. My first question is to Dr. Vishwajit Banerjee, sir. In case of acute infections in people living with diabetes, how do you decide on the domiciliary versus the in-hospital care?
Thank you, Dr. Bhagan, for excellent presentation. This is a very practical situation. In our day-to-day practice, we are in a fix when to admit a patient of diabetes with infection or something to acute infection to hospital. One of my teachers, Professor Agniraj Chaudhary, told us or taught us if you can assess when to shift a patient to a hospital, you are a good clinician. And in this scenario also, there are 2 points to be noted. One is the lab values and one is clinical situation of the patient. As far as the lab values are concerned, a patient with acute infection with diabetes, if they are having extremes of blood sugar levels, either very high blood sugar, we should think about DKA or HHS. extremely high blood sugar level, or if the patient is having extremely low blood sugar levels, recurrent hypoglycemia or something. Why there is recurrent hypoglycemia in this type of patients? Because in many acute infection patients, they are unable to take feed. So this is the number one is level of glycemia. Number two is the how the patient is progressing to the infection. Say one patient is having acute chest infection. What is his SpO2 levels? Whether he or she is having respiratory distress. Say one of the patients is having pyelonephritis or UTI. He or she having low urinary output. Fasciitis, there is spreading infection. So different clinical situations, different problems. So we have to keep in these factors in mind. And one of the most important factor is the blood count, total leukocytic count. It may be very high, or if there is evidence of sepsis, if the infection is progressing, there may be bone marrow depression, low TLC. So these are the broad points I have to mention. Depending on these points, we should take decision whether to admit the patient in a hospital or continue domiciliary treatment.
Yeah, so we are now quite clear on this, that we need to have a clinical judgment, and that should be complemented along with the lab parameters. Sometimes if you think the lab parameters would take about some time to come and you are in doubt, it is always better to admit in those situations rather than take a risky approach of not doing that. So fine, we next move on to the next question. So next question is to Dr. Abhigpal. So nocturnal hypoglycemia versus daytime hypoglycemia. What are the similarities and differences in patient outcomes?
Yes, thank you Dr. Bhaduri for a nice deliberation. As we have already known that one of the most important acute complications of diabetes mellitus is the hypoglycemia. And this hypoglycemia becomes particularly or more grievous if it occurs in the night. And this nocturnal hypoglycemia and recurrent hypoglycemia ultimately continues in a vicious cycle if there is precipitation of the HAAF, that is the hypoglycemia associated autonomic failure. So if those patients who are in the advanced type 2 diabetes mellitus or type 1 diabetes mellitus on insulin, they are skipping their meals, doing some exercise in the evening time, or taking some insulin shots that is not in proportion to their blood sugar level. In those cases, there is always chances of the decrease of the blood sugar level in a critical amount in the nocturnal time. And this nocturnal hypoglycemia is, if it is not treated well, if it is continued, that can ultimately lead to death in bed syndrome also. And also we know that this nocturnal hypoglycemia can lead to Somoki phenomenon, Dawn phenomenon, etc. So there will be increased blood sugar level due to counter-regulatory mechanisms in the morning. So there will be high surge as well as the low in whole of the time, and there is increased glycemic variability in those patients. And these nocturnal hypoglycemic patients need to be treated. They need to be counseled about taking some snacks during the bedtime, or consulting the doctors to check their medications or the insulin so that the adequate amounts should be given, not to do the exercise in the evening time if there is chances of the nocturnal hypoglycemia. So all this should be taken care of.
Right. So thank you, Dr. Pal, for your answer. So I move on to the next question. It's Dr. Arvind Kumar Ojha. How do you differentiate between DKA and HHS in the hospital emergency? So we have discussed a few points in the slide, but in practical, in the hospital emergency, how do you take a call?
Thank you, Dr. Bhadri, for your question. As a matter of fact, the hospital emergency should be the place where these should be diagnosed and the treatment should be started. As the name suggests, DKA, so it has got three essential criteria to diagnose. The patient should have certain level of blood glucose, which nowadays is 200 or more. And many times you know that the patient is diabetic and the other features are there. No amount of glucose is necessary to diagnose diabetic ketoacidosis. So any level of blood glucose in a diabetic patient with presence of ketone and acidosis, it is sufficient to say it is diabetic ketoacidosis. That because we know there is nowadays another entity which is called euglycemic ketoacidosis. So first is blood glucose 200 or more, or patient is diabetic. The second one is there has to be a certain level of ketosis or ketonuria or ketonemia. So if you are able to you have facility to measure the blood glucose, blood ketone, then it should be more than 3 millimole per liter. Or if there is no facility, then it should be 2 plus in the urine at least. With regard to acidosis, the pH should be less than 7.3, or the bicarbonate should be less than 18. So these are the three essential criteria to diagnose diabetic ketoacidosis, and it should be done in emergency itself. The facilities to do this is present in emergency. You need a glucometer only, and you need a ABG. With regard to HHS, there are two criteria, essential criteria, two criteria which should be absent. So the significant ketonuria, ketonemia should be absent, and acidosis should also be absent. And with regard to the blood glucose level, usually it is more than 600, and the osmolality, if you include the urea, then it should be more than 320, and if you don't include urea, then it should be 300.
Fine. Okay, so thank you for the answer, Dr. Anuja. So we move on to the next question is to Dr. Rahul Jain. What are the salient features of electrolyte management in our DKA patients?
Thank you for that question and for your wonderful presentation, my dear friend Dr. Gaurav Bhadavi. So, electrolyte management in diabetic ketoacidosis basically focuses on the important electrolytes, namely sodium, potassium, bicarbonate, phosphate, magnesium, and a host of other smaller, including calcium as well. Now, the point I would like to make here is that it's very important to hydrate the patient. Even sometimes we see patients are coming with hyperkalemia, that is because consequent to the metabolic acidosis, and it corrects with adequate hydration, it corrects with increased blood flow to the kidneys, which results in reduction of secretion of the acid products and potassium. And IV insulin itself is sufficient to cause a reduction in hyperkalemic levels, so much so that many times in patients with borderline potassium levels around 3.5, we actually like to supplement potassium routinely 20 to 40 milliequivalent per liter of fluid that we give, which is 1 to 2 ampules per liter of fluid that we are giving patients while hydrating them or while resuscitating them. So that is very important. The important thing is that if a patient has low potassium, less than 3.5 millimoles per deciliter, then it's very important that we do not start insulin. We first hydrate and we first hydrate and then we give potassium, and then subsequently to start insulin secretion, to start insulin infusion. That is extremely important. Sometimes patients with diabetic ketoacidosis rarely can develop severe hypokalemia, which should be very, very carefully monitored, because hypokalemia is, as you know, a very important harbinger of adverse effects. I've seen many times patients develop serious arrhythmias while they are being treated for diabetic ketoacidosis. The rule of the thumb is to put in a central line. You can supplement up to 20 milliequivalents per hour, which is 1 full ampule of potassium, and of course it should be diluted. One very big caveat here, which I find very often while supplementing potassium, is 2 caveats actually. One is that potassium causes severe thrombophlebitis. The IV site gets inflamed and then gives rise to problems later. So a central line access, central venous access is extremely important. The other thing, which is, if you're putting in a central line and the tip of the central line is in the heart, in the right atrium, then the local concentration of the potassium is higher than in the blood, and that can actually precipitate symptoms of hyperkalemia. Your patient has a potassium of 3.5, but you're seeing sine waves, you're seeing bradycardia and the ECG we want. So these are 2 important caveats. Then coming to sodium, as you know, corrected sodium has to be calculated in patients with diabetic ketoacidosis,
every 4 hours you should do the corrected sodium, and you correct the sodium by 1.6 times the amount the sugar exceeds by 100. So if it is, for example, 400, then 300 divided by 100 into 1.6, which is approximately 4.8. So the actual sodium is much higher. It's important not to correct sodium more than say 8 to 10 milliequivalents per day, otherwise we will precipitate cerebral edema. 2 words about bicarbonate. Do not use bicarbonate as much as possible. Try and avoid using bicarbonate.
So we'll have that question later on.
Yes,
We'll
yes,
discuss.
yes.
Okay. So my next question is to Dr. Supriya Datta. What are the neurological manifestations of HHS, and is there any long-term risk in these patients?
Good morning all. Thank you, Gaurav, for your presentation and for this question. So it has been already discussed what is HHS, and definitely neurological symptoms are the majority of presentation, 40 to 50% or more present with these neurological symptoms, and it ranges from altered mental status, confusion, and it can even progress to seizures and coma. So basic pathophysiology, as you all know about this hyperosmolar hyperglycemic states, it's due to the hyperosmolality due to the increased glucose. So this is responsible for neuronal dehydration and therefore fluid shifts, and there is cerebral neural injuries. So basically there are many other causes also, not only because of this hyperosmolar electrolyte imbalances in both the states, DK as well as HHS, this is responsible, and this occurs mostly in the elderly and with comorbid conditions. And the basic prevention is actually to correct the glucose slowly, because as we discussed about the cerebral edema part also, the glucose should be reduced to the tune of just 50 milligrams to 60 milligrams per hour, and it can mimic a stroke as well. We know that stroke precipitates hyperosmolar hyperglycemic states, whereas it may be the presenting feature also, so we have to distinguish. So to monitor the patient, we have to monitor the glucose, the blood pressure, the GCS, that is more important. And it may be corrected after the correction of this state, or it may have long-term implications, long-term complications. The motor sensory neuro deficit may persist, like there may be a hemiparesis or ataxia or dysarthria, as well as it may progress to a chronic epileptic state also. In some patients we find that, and this dementia and all those are there in the long term. So the basic thing is correction, and also one more important aspect we should remember is the psychological impact of the whole issue. That is more important because patients go into anxiety, depression and fear of the recurrent episodes. So baseline is diabetes, self-management and education, monitoring of glucose, all these basic things which we know, this has to be taught, and patient has to be they should not skip the insulin or the oral hypoglycemic agents, whichever is prescribed, and they should take care of their lifestyle. So this is the basic, and we are all clinicians, we should diagnose and we should prevent the long-term implications of this HHS.
Thank you, ma'am. So the key takeaway I would say from this, other than the entire topic is very important, but the key takeaway is sometimes remember that it can mimic as a stroke, and stroke can also precipitate HHS. So it's very sometimes difficult to identify that in an ICU setup, but we should keep in mind. So the next question is again back to Dr. Banerjee. So what are the special challenges in managing hypoglycemia in our type 2 diabetes patients along with the diabetic kidney disease?
This is a very common situation. In diabetic kidney disease, we often find that patient presented with hypoglycemia or a normal kidney function so far suddenly comes with recurrent hypoglycemia. In those patients, we have to assess whether the patient is going into chronic kidney disease or not. In this situation, a couple of points has to be remembered. In chronic kidney disease or DKD, there is the insulin clearance time is delayed. So short-acting insulin becomes longer-acting. So if the patient is taking pre-mixed insulin, be cautious. You can convert those premixed insulin. If he or she is taking twice daily premix, you can shift to twice daily short-acting insulin. That will also do the work. Or the dose reduction of basal insulin is needed in case of if the patient is having hypoglycemia. Number two, we have to assess what drugs they are taking. Any nephrotoxic drug or any oral hypoglycemic drug which is getting pooled inside the body, leading to recurrent hypoglycemia. I can give an example. If the patient is taking sitagliptin for a long time without assessing their chronic kidney disease or the kidney status, we have to reassess and shift to another kidney-friendly DPP-4 inhibitor. Why this occurs? This occurs because there is impaired renal gluconeogenesis in case of chronic kidney disease, number one. And in case of advanced chronic kidney disease patients, the glycogen storage is not that much in liver, which will take care of hypoglycemia. So these are the main challenges. Another thing we have to keep in mind, if the patient is in dialysis, whether when he is going through the dialysis, the dialysis process per se wash out blood sugar from the circulation, leading to intradialysis hypoglycemia, number one. Number two, if the patient is, and this is for hemodialysis patient, if the patient is going through a peritoneal dialysis, these peritoneal dialysate solutions contain blood sugar, so we have to be vigilant over that. And time and again, I am telling that we have to look about what drugs they are taking, whether that drug is causing hypoglycemia or not.
Okay, so we take the message only regarding DPP-4 inhibitor. Remember that linagliptin is a DPP-4 inhibitor which you can give across the spectrum, same dose. But for other DPP-4 inhibitors, you need to adjust the dose. Everyone is kidney friendly, provided you adjust the dose based on the eGFR. So the next question is to Dr. Agipal. When to suspect lactic acidosis, which is a rare but dangerous complication?
Yeah, thank you, Dr. Bhaduri. I'm just now talking about a complication which is very less talked about and very less touched upon. So lactic acidosis, it means when the lactate level is very high, greater than 5 millimole per liter or greater than 4 milliequivalent per liter in the blood, it is a high anaerobic metabolic acidosis. And this lactic acidosis is not specific to the diabetes mellitus in fact, but diabetes mellitus with some precipitating factors, there will be more chances of the lactic acidosis. What happens when there is more anaerobic metabolism of the glucose and there is more lactate production and lactate excretion is less, there will be more lactate accumulation within the blood. This is known as the lactic acidosis. Anaerobic is very high to the level of the 20 to 30, and this happens, we can divide this as type A and type B. Type A mainly happens in diabetes mellitus when there is some sepsis, there is shock, there is some hypovolemia, there is some hypoxia, any hypoxemic conditions that can precipitate lactic acidosis. Type B happens when there is some renal failure or when there is some hepatic failure, and another most important, when there is any drugs. The drug most importantly associated with this is the fenformin. We all know in the 1970s it has been banned due to the more chances of the lactic acidosis. And we have metformin in the same group, biguanide group. The chances of the lactic acidosis is very less. Nonetheless, there is always chances of the lactic acidosis with metformin. This is known as the metformin associated lactic acidosis, MALA. So metformin is not only the one contributory factor that can lead to lactic acidosis. So in a patient, suppose in a patient of diabetes mellitus who have some decompensated cardiac failure, he or she is taking very high dose of the metformin. There is also chronic kidney disease where the metformin excretion is less, so that there will be more metformin accumulation in the plasma, and that can lead to lactic acidosis. So the takeaway is the metformin not only the only cause that can cause the lactic acidosis, but if there is amalgamation of several other causes, that can lead to lactic acidosis. And this lactic acidosis is very rare, to the tune that if the lactic acidosis is there, the mortality may be 50%. The patient may complain that there may be some weakness, generalized weakness, there may be abdominal pain, there may be dyspnea, and if there is, if this symptoms of patient, we should see what are the blood lactate levels, what is the ANAM gaps, and if the lactic acidosis is diagnosed, then we have to immediately manage these patients. We have to give lots of fluid, we have to give the bicarbonate, and lastly, the most important is the renal replacement therapy. Nonetheless, in spite of all this therapy with lactic acidosis, again I am saying it is a very grave disease, the mortality is approximately 50%. So when we are treating a patient of the diabetes mellitus with multiple comorbidities, and the patient is taking very high dose of the metformin, and if the patient is complaining of non-specific symptoms of weakness, abdominal pain, dyspnea, so we should always think about this lactic acidosis. Maybe the chances of the lactic acidosis is less, but we should always remember that there is chance of lactic acidosis. Otherwise, if we miss, the patient will die.
Yeah, so thank you. So what is the takeaway message is that if you're using metformin in decompensated heart failure, in patients with advanced liver disease, in patients with EGFR of less than 30, then the risk is very high. So in these situations, you shouldn't be using metformin. So the next question is to Dr. Rahul Jain. What are the cardiac complications of severe hypoglycemia and recurrent non-severe hypoglycemia?
Thank you. The cardiac complications of severe hypoglycemia and recurrent non-severe hypoglycemia actually fall into a large spectrum. So, as you know, hypoglycemia releases catecholamines, and adrenaline and noradrenaline, when it's released, basically causes cationic loading of the cardiomyocyte. Every time there is cationic loading of the cardiomyocyte, if you go back to your physiology lectures, what happens is the cardiomyocyte is at a resting membrane potential, and they have these leaky sodium currents, which we call funny sodium currents or funny channels. So when you cationically load a cardiomyocyte, what happens is the resting membrane potential, say, becomes from -75 to -70 or -65 or -60. So the threshold of activation is lower, and hence what we get in clinical practice, the same leaky sodium channels which are leaking in sodium into the cardiomyocyte causes a more depolarization, earlier depolarization, and hence a tachycardia. Also what happens with this tachycardia is that persons with reduced coronary arterial reserve, they are more prone to develop ischemic events, even acute myocardial infarction, higher incidence of heart failure, rate-dependent failure or rate-dependent ischemia as we call it. At the level of the endothelium also, there is endothelial dysfunction in the form of higher incidence of thrombosis. There is increased chances of ventricular arrhythmias because of the prolongation of the QT intervals by the mechanisms I also mentioned. And a lethal combination is if people start developing nocturnal hypoglycemia, they go into this autonomic failure, they are not able to understand what's happening, they are not able to seek help, they are not able to take remedial measures, and they develop QT prolongation. The till 24 hours after every hypoglycemia, the incidence of major adverse cardiovascular events is much higher, to the tune of almost twice the baseline, and autonomic failure. Sometimes these patients also have hypokalemia and hypocalcemia because of the hypocalcemia is very rampant in India, low vitamin D levels. They all cause so many problems such as cardiac arrhythmias, even torsades de pointes. So these are few words on the chronic and complications of hypoglycemia.
Thank you. So we'll move on to the next question. What is hypoglycemic unawareness and can it be reversed? And this question is to Dr. Supriya.
Thank you. So definitely hypoglycemia is a dreaded complication. Patients should recognize the symptoms as was said in the initial, the neuroglycopenic and the autonomic symptoms. And this hypoglycemic unawareness, this is a state where these symptoms are unrecognized by the patients. And this happens due to a long duration of diabetes, recurrent hypoglycemia, as well as patients taking inadvertent dose of insulin or sulfonylureas, and in comorbid conditions as well. And hypoglycemia begets hypoglycemia. This is the dictum. So Long-standing diabetes also has a chance of developing autonomic neuropathy. So those autonomic symptoms, initial tachycardia, tremor and sweating, these are masked. And recurrent hypoglycemia actually brings some changes in the brain, because brain, as you all know, is dependent upon glucose as the source of fuel. And recurrent hypoglycemia actually resets the brain sensitization to glucose. Lower glucose levels, the brain cannot recognize, and there is actually some changes in the glucose transporters and the potassium ATP channels and many other, all the neurons, the glial cells, and they undergo a change due to these recurrent episodes of hypoglycemia. And in the long run, the ventromedial nucleus, it also resets, because that is the site where these hypoglycemia is sensed and glucose setting. And the sympathoadrenal axis, this is altered and also impaired this counter-regulatory hormones. So we know that initially when hypoglycemia starts, the insulin level is the first to be lowered, and then comes those counter-regulatory hormones. Even within the pancreas also, the glucagon levels, they are also lower. So these are all pathophysiologic changes which are occurring if there is recurrent hypoglycemia, and that term has been used previously, hypoglycemia associated autonomic failure. So all these are a vicious cycle which goes on, and in the long run it is complicating to the patient, and definitely it is life-threatening. These are the implications. So is it reversible? Yes. Initially, if we take care of managing the hypoglycemia, same thing, the patient education comes into the foray, the monitoring, the CGM is the best gold standard, but if it is not available, at least we can guide them to a structured SMBT and proper timing of the diet, exercise, because this is one thing, exercise and alcohol binge, these are responsible for hypoglycemia. It has already been discussed previously. So this is a dreaded complication, and it can be reversed by taking care of the hypoglycemia for at least 2 to 4 weeks. You set a higher level, and in elderly and patients with comorbid conditions, the targets should be actually not that.
Yes, so thank you, ma'am. So hypoglycemic unawareness is a very big problem, and the important takeaway message is that can it be reversed? And the answer is yes. So there have been studies on this where they have tried to make sure that the patient doesn't land up in hypoglycemia for a couple of weeks to months, and then they found that the response to hypoglycemia came back. So that is some takeaway message we must carry forward. So the next question is, when do you suspect a euglycemic TKA, and how do you finally clinch the diagnosis? The question is to Dr. Arvind Kumar Ojha.
Thank you. Actually, the euglycemic decay had been more commonly known nowadays after the usage of SGLT2 has been in the last few years. But this entity had been there for quite some time, especially many times the similar thing has been seen in pregnant patients, in CAD patients, the patient who had been taking alcohols, and the patient who had been fasting and not taking sufficient amount of glucose. So if you have this category of patient, then you should be suspecting euglycemic decay when there is features of ketoacidosis.
Yes.
So this is one which.
So like ketoacidosis with a blood sugar which is less than 250 is where you should suspect.
It is euglycemic.
Yeah.
So the name itself suggests. And how to clinch the diagnosis by doing these certain measures that we have already discussed. And the difference, the importance of recognizing this is because the treatment begins in the ER itself. Because the quality of fluid management changes from the very onset. You have to give glucose from the very onset rather than giving only the normal saline or crystalline solutions in the normal decay.
So thank you. So we move on to the next questions, and we will just ask the panelists to answer in 1 minute time so that we have some time left for question and answers from the audience. So the next question is to Dr. Vishwadeep Banerjee. What are the long-term sequelae of severe hypoglycemia?
I will divide the long-term sequelae of severe hypoglycemia in three parts. One is neurological complications sequelae, cardiovascular and psychological. I will not discuss about the cardiological because it has been just before discussed by Dr. Jain. So neurological, there may be, the most important is the cognitive dysfunction. If the patient is having recurrent severe hypoglycemia, the cognition is impaired, decision making function is impaired. In case of children, type 1 diabetes, in the long run, the IQ is depressed or is reduced. And in extreme case, there may be coma, seizure and all these things. Number one. Number two, as far as the psychological part is concerned, this is very, very important. The patient starts taking defensive snacking. They don't try to control blood sugar very tightly. Number one. Number two is if the patient is on insulin or an insulin naive patient, once they have got hypoglycemia after taking insulin, it is very, very difficult for physicians like us to convince them to continue taking insulin. So psychological component is very, very important. Defensive snacking is very, very important. And as far as the neurological part is concerned, in my opinion, cognitive function development is very important.
Thank you, sir. So the next question is to Dr. Arvind Kumar Oja. Is there any role of bicarbonate in the management of DKA? A very brief answer, sir.
In one word, no.
No.
But sometimes you have to use, especially when age is less than 7, or if the patient have got the problem and along with CKD. So in various resolution, but in one word, it's no.
Yes. So that's the take-home message that for most of the cases, we don't need bicarbonate to manage DKA. So the next question is to Dr. Rahul Jain. Why do we follow the fluid first approach in DKA, and which fluid to use and how much and when to stop? Very brief answer.
Okay, very briefly. So basically fluid first is because physiologically the patients are extremely volume depleted to the tune of almost 5 to 8 liters, which is why you should replenish fluids. Which fluid to use? Well, normal saline is the gold standard which people use. I, however, do not use normal saline. I use balanced crystalloid solutions because that mitigates and minimizes the risk of hyperchloremic non-anion gap metabolic acidosis later. And also the sodium load is slightly low. The chloride load is much lower. Instead of 154, it is only 90 milligrams per liter. And the important thing here is that when you hydrate the patients, ketones are washed out, are excreted by the kidney, so is excess glucose. So only by giving fluid, you can actually reduce very drastically the blood sugar. And when to stop? So you have to assess clinically. You have to see what is the JVP like, what whether signs of dehydration are present, what is the blood pressure, what is the pulse, importantly, what is the IVC diameter, what is the collapsibility of the IVC, what is the urine output. When it is adequate, when you've confirmed that you've filled the patient adequately, I think it is time to stop.
Beautiful, beautiful. So very nice answer, Dr. Jain. So I move on to the next question to Dr. Supriya Datta. What are the atypical infections with acute manifestations in people living with diabetes?
So it has already been highlighted in your slide. I'll just briefly name them, remind them again. So one of the common things which we saw in the COVID-19 pandemic is the mucormycosis or zygomycosis. This is very common, rhinoorbital and presenting with blackish scar, and it is very debilitating. So this amphotericin B or surgical debridement is necessary. And apart from that, we have the malignant otitis externa caused by Pseudomonas aeruginosa. This is also life-threatening, presenting with neurological symptoms and cranial nerve deficits. Apart from that, commonly we can find these necrotizing lesions, necrotizing pyelonephritis, fasciitis, the cystitis, as well as necrotizing this cholecystitis. So these are all gas-forming organisms which, due to the immune condition in a hyperglycemic state. Apart from that, we also have this fasciitis, soft tissue infections, and corneous gangrene. It is a common and initial days of SGLT2 inhibitor use also without proper guiding the patient. This was seen in some of the patients. And apart from that, we can have soft tissue infection. So these are atypical and we have to suspect and find out, and they all present in this febrile state and sepsis and all those. So I think this is clinical diagnosis and management should be prompt.
Yes, so prompt management, institution of the prompt management is very important, especially in patients when we are using SGLT2. It's very important also to make sure that the patient is aware of something like 4 years gangrene, the possibility of that happening, and then reporting to you as fast as possible. So the next question is to Dr. Nepal. Does CGM improve the outcomes in hyperglycemic emergencies like the DKA and
Yes, thank you, Dr. Bhaduri. So I am ending the panel discussions with the discussion on this newer technology. So continuous glucose monitoring. All of we know that mainly it is used in OPD basis, but again there are very few studies which can show that if we are using this CGM in predicting the actionable advanced warnings in the hyperglycemic emergencies, that can be beneficial for the patients. For example, recently in 2024 in the Journal of Diabetics, Therapeutics and Technology by Gilliam et al., publications have come, research has come which mainly inspects 2 case control studies over 3,000 individuals who are on CGM devices. And they have seen that if there are different types of the CGM metrics, if the patients are on CGM, there will be more chances of the picking up the hyperglycemic emergency and also the hypoglycemic emergencies, and there will be less hospital visit, less emergency visit, less morbidity and mortality. So from this we can say that not only in the OPD but in the IPD also we can use the CGM devices. Apart from this, if there is any history of the diabetic ketoacidosis, history of the HHS, history of the recurrent hypoglycemia, if we are using these CGM devices, there will be more chance that the patients will not precipitate these emergencies.
Right. So it's now today the emerging evidence is probably saying that CGM may have a very important role not only in management but also in preventing this these acute emergencies. So thanks to all the panel for their beautiful replies, and we have tried to cover a lot of the different parts of acute complications of diabetes. So I leave open the session for a question and answer from the audience. We have very limited time, so maybe a couple of questions, if any.
My question is, in HSS, main problem is hyperosmolarity, and management, intensive fluid management is enough to reduce blood glucose. If ketone is low, the 3-beta-butyric rate is less than 1 millimole per liter, can you treat the patient without insulin?
Without insulin. So any panel members want to take this question?
Now, insulin, you have to give what is the blood sugar level. Obviously, you have to use insulin. Hydration remains the cornerstone of management of hyperosmolar state. But having said that, there is a relative deficiency of insulin, for which you have to give exogenous insulin. You will have to give. That is the treatment. You can't rely on any other drug in a HHS. I mean, you can't obviously go give oral drugs. And what drug are you going to use? You are going to have to use insulin, albeit at a much lower dose. And after sufficiently hydrating the patient, use maybe 0.5 units per 0.05 or 0.025 units per kg per hour. That's what you have to give insulin.
So even if you are like, if the patient is dropping their sugars by 30 to 50 milligram per hour, so be very happy about it. There's nothing, don't try and rush to bring the sugar down. So that's the takeaway message. Even if it is a very, very small percentage reduction you were seeing in the initial hours, be extremely happy about it. So there's no problem in doing that.
So, sir, to answer it, it has already been answered. The levels are more than 600. That is one thing. And fluid will not get it down to any level, and no OHs can be used in that state. So, it should be always insulin. in a rate-controlled manner so as to prevent separately and all those complications.
And withhold insulin till the potassium is less than 3.5.
Yeah. So that's we have discussed here. So I thank everyone for this. First of all, I thank the panel for the fantastic answers, and I thank the audience also for listening to this entire session with so much of patience and also asking questions. Thank you. So we can have a follow-up.